thank you so much for the opportunity to be able to speak here with you about my work and also the work of some of my colleagues. As Naomi kindly mentioned, I do hail from California. Way back in 1995, I moved to Miami. My 11-year-old says, "Oh, that's back in the 1900s, Mom." You're right. I guess it is getting to be a long time ago. I came here to train in otolaryngology with Dr. Goodwin, whom I'm sure many of you are familiar with. He has just been a dear mentor to me in my young adulthood and as I move into the middle stages of my practice, and it's truly been an honor to work with him as well. My research started back very shortly after I arrived with Dr. Lily Bourguignon. She'd since moved to UCSF, but she was working on a molecule called CD44 with some very interesting mechanisms of action. It's found normally in most cells of the body, but in cancer it becomes dysregulated, and different forms, it's still called CD44, but with slightly different molecular structure, become overexpressed in the situation of cancer. And so trying to understand that has opened the field in many ways as we find ways that we can detect cancers and potentially treat them. So in the meantime, in my residency, I was working, that's when I started working with the population at Jackson Memorial Hospital, and as you know, mainly an underfunded and under-resourced population. And I've been working with them now since 1995 as well. And it really struck me. I've always been interested in cancer. I've always been interested in helping the less privileged financially. But what was really frustrating is that these people would come in with huge tumors, just coming out of their heads, and it's just access issues and not knowing about the disease that led to this. Now, the problem is magnified in this population, but really the problem of late detection with head and neck cancer is really generalizable to all populations. It just gets worse when you don't have resources. And so it became something that really, really struck me, because, well, I really love doing surgery, and it's exciting and interesting, and it keeps the adrenaline going. It's really frustrating to operate on someone and then have them, lose their voice box, lose the ability to swallow many times, and then they're telling you about their family gatherings where they're having to eat out of a tube that's stuck in their stomach, rather than having normal social interaction of eating a meal. And it's frustrating. And then even more frustrating are the people that you do this huge operation and they've barely recovered and the tumor is back, no matter what you throw at it. Chemotherapy, surgery, radiation. It can be a very, very aggressive disease when it's caught late, and when it's caught early, we can cure it 90% of the time. And so it's that balance between seeing the patients, talking to them. As a head and neck surgeon, you really get to know your patients because you're following them initially every 6 weeks. Then it slows down a little bit, but you really get to know these people, and that's really my motivation for my work. When I got further along in my training, I actually did my fellowship also at Jackson facilities, and there I came in contact with Vinata Lokeshwar, who I think many of you probably know as well. She does bladder and prostate cancer research, and I worked in her lab for a little bit, and we learned about tumor markers and bodily fluids and early detection from her. And then what we did was I combined kind of what I learned about the detecting markers in bodily fluids and what I'd learned from Dr. Bourguignon with CD44, and we combined that into a test and began studying it. We started getting little bits of funding and then bigger and bigger bits of funding from foundations, from NIH, from the state. And so that's how the test developed. We recently completed enrollment to one of our NIH studies. That we completed the enrollment in the end of 2012, and then it takes about, when you have larger numbers of patients, it takes almost a year to analyze the data, make sure that you've really figured it out and double-checked and triple-checked all the data. And so we finally put together a manuscript that's not quite out published yet, but it's in the review process. And basically, we had enrolled 150 patients from both Sylvester and Jackson, about half and half, and then 150 patients that were coming to primary care clinics associated with Jackson and UM. And we tried to make them equal with respect to the gender, the age, the race, socioeconomic status, and the risk factors of tobacco and alcohol use. And then we used some analysis software, which helped to pick the cut points for CD44 and another marker, which is just regular, the amount of protein that you're producing in the oral rinse. It turns out that that's a very simple and inexpensive marker that works pretty well. And we found that with that analysis software, we were able to get to some cut points that predicted those patients that were at higher risk for developing cancer. And depending on the cut point, your risk could be 10 times higher, risk could be 2 times higher, but anybody who was at significantly increased risk was somebody that we wanted to follow. And so with that study, you can imagine that the people coming to the primary care clinics at Jackson and at UM probably are probably fairly sick to begin with, or not quite as healthy. I don't know. Many people try to go to primary care closer to their house or wherever it's more convenient. And so we did find that a lot of those patients actually had a history of cancer. Because we were matching them for age, they tended to be older than the population that we were hoping to screen. So then we wrote another study that was funded by the state, the Bankhead-Coley funds, and for that study we went into Liberty City, and we enrolled 150 patients from Liberty City who were also at risk, but they were about a decade younger, which is, we want to start screening early, like around 40, not at 60, which is where the age match controls were. And so when we did the study in that population, the specificity, the ability of the test to really identify the people that had a problem went up, even though that population, are you guys familiar with where Liberty City is? Yeah, so it's the population is very poor. Unfortunately, they don't have a lot of access to oral health and dental care. They were all smokers, many of them drinkers, and so even in that population where you would expect that there would be a lot of people, that maybe everybody would be positive on a test, they weren't. And so what that showed us is that it seems to really be picking out the people that are most at risk. And then in all of the studies that we've done, we've always had a couple of people that had high levels that then went on to develop cancer. So the challenges with these kind of studies is that you really have to follow people over a long time to know if they're going to develop cancer or not. This disease, you can have dysplasia about anywhere between 2 to 15 years before the lesion actually shows up. So the good news is that you can also, the disease, if you catch it early enough, it's reversible, and you can actually get the disease to go away. And so stopping smoking, taking better care of your teeth, eating a better diet may actually improve the situation if you catch it early enough. And we have found that with this test in that Liberty City population, when we followed them over a year, we were giving them a lot of education, and we were showing them where they could go for their oral health, where they can see a dentist, and taught them about good nutrition and eating lots of fruits and vegetables, staying away from sugar and simple carbohydrates. And by golly, the levels actually were going down in that community over time. And we did a few analyses to see, well, did the test change? Is it just something technical? And from all the analyses that we did, we couldn't see anything technical that had changed over a year. It seems that the risk is actually going down. And so also during this time, around 2011, a company, as Naomi mentioned, Vigilant Biosciences, became interested in the technology. The CEO is, his name is Matthew Kim, and both of his parents, interestingly enough, have had head and neck cancer. It's unbelievable, because while it's a fairly common cancer, it's one of the more common ones in the United States, it's not as common as lung. So it's about 10 per 100,000 people that get it. So it's really amazing that both of his parents got it. But he and his family are just wonderful people, and he's very motivated to find a cure for this disease and for cancer in general. And so his company, he started this company. They've won a number of awards and so forth, and they're working on commercializing the technology, and also they've converted it to an even easier format. So what I've been doing in the lab is called ELISA, and we also do a protein assay. It's typically done on 96 well plates. It requires a person to do the testing. There's a lot of washing, there's a lot of steps, and so it's more expensive because you have to pay for that person, or ultimately you'd pay for a robot to do that, but it's still going to be super expensive. Well, his company has converted this to a lateral flow test strip, like a pregnancy test. And so now it's super easy and super inexpensive to test people, and we can identify those people that are at risk. We can encourage them to have a healthy lifestyle, because maybe you can get those levels to come down before anything develops. And if not, we have the opportunity to catch it earlier. And so that's where we're at with that. Also, as I've become very interested in CD44, and from my work with Dr. Bourguignon, the mechanisms of CD44, and over the years, other groups have shown that this is actually a cancer stem cell marker. Are you guys familiar with cancer stem cell concept? Okay, so it's these are the cells that get the cancer going. They're also called tumor-initiating cells. These are the bad guys, and it turns out that CD44 is present at high levels on these. The cells that get more differentiated and are not the ones that are regenerating the tumor. Those ones sometimes lose CD44, but it's the cancer stem cells that actually have it. And so it would be wonderful if we could target that marker, because we know that it's not just a marker, it also is associated with tumor proliferation, with migration and invasion and things like that. And so my lab is also working with a company to develop a therapeutic, and we're hoping that we can start clinical trials with that pretty soon. We have a paper that discusses some of the mechanisms that are involved with this particular, it's a monoclonal antibody. And interestingly, we're finding that it not only targets the CD44 on the cancer cell, but it also helps the immune system to become more active, particularly with the natural killer cells, which are part of the immune system that go and attack the cancer cells. And so it appears to be stimulating those, and hopefully that data in detail will be coming out soon as well. And so that's really pretty much what we have, kind of a wrap-up. I'm sure I've missed something, because there's so much going on in our group and so much that we would like to do, but hopefully that gives you a flavor of what we're trying to do at Sylvester with head and neck cancer. Thank you.
Are you not on, Barbara?
Here, do you want to? We can pass it back and forth.
If there are any questions, here. What?
Is it possible to transmit oral HPV if somebody has an HPV-associated cancer via oral transmission, person to person?
So generally the teaching on that is pretty much no, that you can't. the reason that we say that is we have a lot of people now with HPV cancer, oropharyngeal cancer, and their wives and husbands aren't coming in with the disease. You see it very rarely, so I can't say it never happens. But we're not seeing it at the level where it's causing us as practitioners to recommend changes in behavior, particularly in patients who are in monogamous relationships and so forth. But always the routine pap smear and whatever routine testing you normally would do, your colonoscopies, all of that stuff should still be done.
Going back to the oral part of what you had said about the spit, there are many dentists that are using it. Is there something new with the strips that you had mentioned? Do the strip and tell immediately?
Right. So with the strips will be something that you can tell right away in the clinic what it is, and it's mainly looking for people who are at risk for oral cancer, and it tells us what the risk is, basically, and affords the opportunity to help them change their behaviors to decrease their risk, and also keeps us vigilant with respect to their follow-up. So if they have really high levels, we might want them to go to a specialist and have a fiber optic exam in addition to what you normally would get at the dentist, that sort of thing.
Right. Thank you. Anyone?
You mentioned that Cialis stimulates the immune system if somebody has a compromised immune system. Is that for women as well as men?
Yes. Yeah.
Anyone else?
And again, that study is still undergoing investigation. It has not gone into phase 1, 2 testing yet, but that's one of the things that they want to do. So we hope that there'll be clinical trials soon to look into exactly the benefit.
Would you happen to know any of the signs for throat cancer?
Of course. Sure, let's talk about that. It's important. So the risk factors, first of all, are tobacco use, alcohol use, and the human papillomavirus. But those are the ones that most people know. But there's also family history. If you have a family history, you're more likely to get it. Certain other environmental exposures can make you more likely to get it. A diet without lots of vegetables can actually put you at risk as well. So what we're looking for is a white or a red lesion or a mixed lesion that's in the mouth or in the throat. It can be raised, it can be flat or even ulcerated a little bit. And if it's been there for more than 2 to 3 weeks, that's when we start getting concerned, and it should be looked at and followed and perhaps biopsied, depending on what the exact characteristics are that your dentist or your surgeon see. Other sign, there's also you can get lumps or bumps in the neck. Unfortunately, that's a little later stage. With HPV infection, we often see lumps or bumps, and that is not a death sentence. It can still be cured at that stage. So, the main thing is to get these things as early as possible. Other signs that we hear and symptoms are the throat discomfort, a hoarse voice is an early sign, bad breath that you can't get rid of with normal oral maintenance, and ear pain, believe it or not, because we get referred pain just like when you have a heart attack. You can get pain referred to the left shoulder. With throat cancer, you can get pain referred up to the ear.
Thank you. Anyone else? Thank you so much, Dr. Franzmann.
Thank you all very much.